Buenos días. Quiero informarles que esta sesión va a ser en inglés, y porque tenemos invitados en inglés y creo que es importante que todas las preguntas y toda la interacción sea en inglés. Si alguien quiere preguntar en castellano, en español, está bien. Y voy a empezar ya dando la bienvenida a nuestros conferenciantes. So, good morning. We have this session, it's Hot Topics in Cardiology 1. It's for us a pleasure to have the invited speakers that will appear in this session, will give us their lectures that are, all of them are world experts in cardiology, and I think it's for us an honor to have them with us. I'm sorry because the talks will be, and all the session will be in English, and I see two people leaving, so we have to work this out. But I think it's a matter of interest to have it in English. Another thing that is important today is that this session will be passed on in real time in the web. So members of the society that have not been able to be here will be able to watch us, and also will be able to pose questions to us through Twitter. And we have here an expert in Twitter who will be the facilitator of the questions that can be sent to us from outside and also from this room. So this is a novelty, this is something that we are doing for the first time, and we hope that will be a success. So I am Lina Badimon, I am the president of this meeting, and I am the vice president of the Spanish Society of Cardiology, and I have the pleasure to have as co-chair the president of the Spanish Society of Cardiology, Professor González Juanetey, and Agustín Fernández Cisnal, who will be the cardiologist expert in Twitter streaming. So with no further talk, I'd like to invite Professor Keith Fox, who will be presenting on the highlights of the ESC Congress 2014.
Gracias. Buenos días. My apologies that this has to be in English, but my thanks to you, Lina, and to Jose Ramon. It's great to be here. So I've been asked to talk about some of the highlights from our European Society of Cardiology Congress, and these highlights were chosen by experts in all of the fields. So I am simply reflecting those highlights. First, a few facts. We had 30,330 registered participants from 144 countries. We had nearly 11,500 abstracts submitted and 230 hotlines submitted. And we had faculty and presenters from 81 countries. And we're delighted that Spain was among the top, both in terms of abstract submitters and also faculty. And these are the faculty representation. So we have a broad concept of Europe. And just before we leave that, I come from this tiny little bit of United Kingdom called Scotland, and I'm pleased to say that it is still United Kingdom and part of Europe. So our theme for the Congress was innovation and the heart. And here we have an amazing fusion of science and art. This is a 2-day-old zebrafish heart with labeling of the surface receptors in the heart as the tube starts to fold. And here is an intact mouse heart with superb resolution from optical projection tomography. So it's first of all heart failure. This was one of the highlights of the Congress. This is the study Paradigm HF, an angiotensin receptor neprilysin inhibitor. So it's a combined receptor blocker and inhibitor of neprilysin. What it showed was remarkable, which is against what was demonstrated to be effective dose of enalapril. There was an additional 20% reduction in cardiovascular death or heart failure hospitalization. So these are ambulant patients who are already well treated. And even cardiovascular death, an additional 20% reduction in cardiovascular death. So if you were to be asked before this, would you expect an additional reduction on top of what has been achieved before? Many of us would not. So this is the benefit that was seen with angiotensin receptor blockers, the benefit with ACE inhibitors, and the additional benefit with this combination. And thankfully, the neprilysin inhibitor did not have any excess of angioedema. So the next interesting topic was the issue of iron deficiency. Iron deficiency and functional capacity in heart failure. This is not just individuals with anemia, but actually with iron deficiency alone. And you can see that there was a change and improvement in the walking test by replacing the iron, and an improvement in first hospitalization due to worsening heart failure. So perhaps an important and interesting message about these outcomes. Turning to arrhythmias, we know that in the past, obviously quinidine is indicated in the Brugada syndrome and arrhythmic storms. What the investigators tested in this trial was in those with ICD implantation and shocks, whether quinidine reduces the number of shocks. And interestingly, there was about an 80% reduction. So an application that has not been used widely in the past. There was presentations of the wearable defibrillator with low rates of inappropriate shocks and no deaths, and it may be used as a bridge in these settings. Obviously, there's also the developments of the subcutaneous defibrillator, and that has important applications as well. So there may be important data from that. I now touch on acute coronary syndromes, and perhaps one of the studies that is important in terms of clinical application is this T-Rapid AMI study. So multi-center, and it evaluated a one-hour algorithm for diagnosing myocardial infarction. The key message is that you're able to rule out MI with a negative predictive value of 99.1% in 1 hour. So this has potentially important applications in our hospitals. It is less accurate in terms of positive predictive value, but rule-outs, really important. In intervention, Gilles Montelesco presented this trial of pre-hospital or in-hospital ticagrelor, and there was no overall difference in the composite endpoint. No difference in bleeding. But what it did show, and this is as a subsidiary analysis, is an interesting but significant trend with less stent thrombosis. So it can be used prior to primary PCI. It's safe, but it doesn't actually improve the hard outcome events. Now, there was an interesting trial from the UK, which was small, only about 300 patients, multivessel disease, testing the question, do you revascularize only the index artery in primary PCI or complete revascularization? And this was mostly done at the same sitting. So this was the primary endpoint. The results were interesting in that there was a significant reduction in the outcomes as a result of this complete revascularization, so improvement. And you can see the individual components, all-cause mortality, recurrent MI, heart failure, and repeat revascularization. So interesting trends. But my view is that this is not definitive. It's a relatively modest-sized study, and there is a much larger study, the complete study, which is testing something slightly different, which is staged revascularization. And we should have the results of that trial next year. Now, what about TASTE? TASTE was very interesting, Scandinavian study that used a registry as the basis, excuse me, as the basis for randomization in this trial. And we know that there was controversy when this was first presented with 30-day data, which showed no evidence of a difference in outcome. So now we have the 12-month data, no difference. So no evidence that thrombus aspiration helps in terms of hard, definitive outcomes, and no benefit in any particular subgroup. What about blood pressure lowering, prevention? And this is hypertension. So here we have something interesting, which is the 10-year follow-up in diabetes. And what it shows is that there is a persistent benefit in terms of this impact of blood pressure lowering on all-cause mortality and cardiovascular death. So blood pressure lowering, type 2 diabetes, very important. And now we move on to the Simplicity Registry. And this is across 245 sites, excuse me, in 37 countries. And what it shows is, first of all, that in all patients, there was about a 10 millimeter drop in office systolic blood pressure, slightly more at 6 months and slightly more at 12 months. Thank you. And not surprisingly, the higher the blood pressure, this is 140, 159, 160, 179, greater than 180, the greater the blood pressure, the bigger the effect. So interesting data from an observational registry, but the trial, HTN3, the 6-month primary efficacy endpoint, denervation and sham, there was no difference, no significant difference, a delta of only 2 millimeters. So really highlighting the importance of having a randomized trial. So it's safe, but no difference in adverse effects. And the original therapy, there was a planned crossover, and this reinforced the results. Now moving to TAVI, what have we learned? There's really a huge experience now, more than 10,000 patients. And we have, for the first time, 5-year outcomes, you can see here. And the demographics and comorbidity have determined. The durability looks encouraging, and obviously we need future data. So these are the data across the different studies, and here all the way out to 5 years. This is a very good example of how a registry program run by the ESC can give us data that single centers or single countries cannot. So this is the registry of pregnancy and cardiac disease and the role of mechanical prostheses. And really it shows very clearly that those with mechanical valves versus tissue valves versus no prosthetic valve, there is a difference in outcome. Obviously, the patients are different. And vitamin K antagonists are associated with a high offspring mortality, miscarriage, heparin use associated with valve thrombosis, and no single regime is optimal. So there's huge scope still to be done in this population. I'm not going to touch much on imaging because I know Professor Pinto is going to be covering that, but this is one of the studies that shows a remote amplification of inflammation in relation to the stable angina, non-STEMI, and STEMI. And this shows that the epicardial adipose tissue can predict progression of coronary calcification, and Fausto may touch on that one as well. One interesting analysis, and I declare an interest as the prime investigator of GRACE, but I did not select to this trial for the highlights, that the extent of MI predicts early recurrent MI. So it exacerbates systemic atherosclerosis and inflammation and causes an increase in recurrent events. So some interesting findings. Now, Kim Fox presented the Signify trial, which is ivabradine, and this is in stable patients. And what it showed overall is that there was no difference in outcomes in this population, no difference in outcomes, and actually there was an excess hazard. So a word of caution about ivabradine in that population. And here is the background for the solid TIMI52 trial. This is the lipoprotein-associated phospholipase, LPPLA2, which is a beautiful hypothesis. So this is the native LDL, the amplification of oxidized LPL, and then LPPLA2, resulting in these products that increase inflammation and necrotic core. So a beautiful hypothesis slain by the evidence. A very well-conducted trial, very high rates of secondary prevention, and absolutely no difference in outcomes. But please note one thing. These are very well-treated patients. At 3 years, the event rate is 15 to 16% post-ACS. So we have not fixed this problem. Let's move on to PCSK9. This is a novel target to lower LDL, and you can see the mechanisms of action and the changes in the vessel wall. So the Odyssey studies are one of the PCSK9 inhibitors, and there are others produced by other companies, and this is testing alirocumab, which is an injectable every 2 weeks, monoclonal. So against placebo and on top of maximum tolerated statins. And what you can see is that there is a truly remarkable reduction in LDL. Very striking. And if we thought we'd achieved the maximum with statins, the answer is no. And very excitingly, for the first time, there were results out to 84 weeks, median 65 weeks, showing a change in outcomes, the first major adjudicated cardiovascular event, in favor of the PCSK9 inhibitor. So potentially exciting information. And I'm going to close with some information about our digital content. You know that we have ESC Congress 365, which is available to all of us throughout the year. So materials from our Congress are available. We have the programs of Best of ESC, the ESC TV, and actually the live views of our Congress during the Congress went out to 93,000 viewers. Physicians are now very savvy in terms of the mobile app. 19,000 downloads, 3/4 of all physicians downloaded the mobile app and guided them through the Congress. I recommend to do this. Congress 365, truly remarkable. We have had 1.9 million page views, 300,000 unique viewers. And as you're doing here with tweets, these reached 65,000 people, including the program that we did with medical students. So I think the reach of the Congress is substantial, and it extends beyond the days of the Congress itself. Thank you very much.
Thank you very much, Professor Fox. The discussion will be at the end with everybody here at the desk.
So, first of all, I would like to thank our international guests for coming to Santiago, and mainly for their terrific, outstanding scientific contribution to this Congress. And it's to me a great pleasure to introduce the talk of Fausto Pinto. Fausto Pinto is the president of the European Society of Cardiology. He is doing a tremendous work in this very important society, not only for the physicians, but also for the social and the social objective to reduce the burden of the cardiovascular diseases all over the world, and particularly in Europe. And Fausto Pinto is a great friend of the Spanish Society, and particularly mine. And for me, this is the reason it's a great pleasure to introduce and to welcome to Fausto to Santiago. Fausto, bem-vindo a Santiago, bem-vindo a casa.
Muchas gracias, José Ramón. Thank you very much. It's a real privilege to be here today. I really feel at home when I'm here in Spain. It's just next door to my country. And I really feel particularly at home when I'm with such good friends as José Ramón or Lina, who, by the way, is sitting in our board now of the ESC, and I'm very happy to have a strong contribution from the Spanish community to the ESC and to what we are doing here, or trying to do here in Europe, to improve the way we can manage our patients, we can reduce the burden of cardiovascular disease, and also promote healthy lifestyles. So my task now, and by the way, I really want here publicly to congratulate Keith Fox for the excellent work he has done as chair of our Congress over these last 2 years. It was really fantastic, and as you've just seen from his presentation, there were a lot of different areas that were covered during our Congress. We are basically 365, so we cover the whole spectrum of cardiovascular diseases, and it's been really amazing how the amount of abstracts of science, of new trials that were presented at our Congress. And my task now is give you a little bit of the flavor of what was presented in the area of cardiovascular imaging. Imaging, as we know, it's been growing in an exponential way over the last few years, and not only in terms of technological developments, but also in the way that imaging now is used in clinical practice. So I will divide this talk, which, by the way, this is based on the presentation that Patricio Lancelotti prepared for the highlights of our ESC Congress, and I will be covering 3 main topics. So the first one is to show how much imaging now is included in our guidelines. And this is something relatively new, because until recently, imaging was considered almost like, okay, it's nice, but was not really included in the core of our guidelines. And we have now, and that's due to many reasons. As we know, it's difficult to get hard data. It's difficult to have good trials where imaging is involved. And so the amount of data now is being accumulated in a way that can be now included. The evidence now is robust enough to be included in the guidelines. So that will be my first part, is how imaging now is included in our new ESC guidelines that were presented in Barcelona. The second one, and Keith already gave you a little bit of a flavor, is how imaging now can actually be used to image atherosclerosis. And I will also show you how it can be used as a risk marker, and we'll discuss a little bit around that. And finally, one important area in cardiology, which is left ventricular function assessment, again, how imaging can help us to improve the way we can assess left ventricular function. So let me talk a little bit now about the use of imaging in our new guidelines. There were 5 new guidelines that were presented at the ESC Congress, and this was one of them, the revised guidelines on myocardial revascularization. And this was actually done together between the ESC and the EACTS, which is the Society of Cardiothoracic Surgeons. And now imaging is included in the guidelines for myocardial revascularization. The use of stress imaging is a 1A indication, which means that it's indicated to be performed and based on the level of evidence A, which means that there are trials justifying the use and providing the evidence of the use of stress imaging for selecting patients for myocardial revascularization. And this is particularly important, and that's where the indication is placed in the patients with intermediate risk. And this is actually the group of patients where we have sometimes more difficulty in selecting these patients for revascularization. Another important indication of imaging is actually the upgrade on the use or on the indications of CT angio, which is now a 2A indication based on a class of evidence A, and again, particularly for this intermediate risk group of patients. And also for the first time, hybrid imaging, and you have here a selection of 2 images which provide you a combination of 2 different imaging modalities. And the concept here is that we can take advantage of the important features of one modality together with another modality, meaning one modality which will provide more anatomic information, and one modality like CT angio, and one modality that can provide you more functional assessment. And put this together, you can actually match anatomy and function, and we know today how important it is to use both of these assessments and not being just based on the anatomy, for instance. Thank you. So the other important use of imaging in the second guidelines were the guidelines on aortic diseases. We released guidelines for the management of patients with aortic disease, and here the use of imaging and of the different imaging modalities, and by the way, and I've been defending this for a long time, imaging is a tool. From a clinical standpoint, imaging should be seen, in my view, as a tool, and we should use the best tools that can help us to do patient management. So I was always a little bit against this thing of echo versus nuclear or versus MRI or versus CT. What we do need as physicians is to have the best information that can be withdrawn from the different imaging modalities so we can apply for better patient management. So here is a very good example on how the different imaging modalities can actually complement each other and help us to improve the way we can accurately assess patients with aortic disease, different sets of aortic disease, from acute aortic syndromes, aortic dissection, aneurysms, and so on. And important recommendations on these guidelines on the use of imaging is the fact that over time, most of these patients will need repetitive imaging. And therefore, it's very important that the imaging modality should be, at least one of the imaging modalities should be the same. It doesn't matter what, but should be which, but it should be the same so we can actually have the same references. There should be a similar method of measurement that should be used on the follow-up of these patients. And again, as much as possible to use the lowest iatrogenic risk imaging modality if possible. The third guideline that was produced was on hypertrophic cardiomyopathy, and here we know that echo has been playing a central role in the diagnosis and monitoring of these patients. It's a 1A indication. It's also important for the detection of increased left ventricular wall thickness, as we know, for some presentation and demonstration of some of the disease phenotype, like the presence of myocardial fibrosis, abnormal mitral valve apparatus, and so on. But more and more, magnetic resonance is increasing its relevance on the study of these patients. And for instance, now it is recommended that the use of CMR should be performed and interpreted by teams who are experienced in cardiac imaging, and this is a 1C indication now. And also, if there is no contraindication, the use of late gadolinium enhancement is also recommended, so it can demonstrate, for instance, the presence of fibrosis, which we know today is a prognostic indicator, particularly for the development of arrhythmias in these patients. And actually, if we look at the registry on cardiomyopathies, which is the European registry, we can see already that a substantial number of patients, and these are the first 1,100 patients that were studied in this registry, already more than half of these patients, they had the CMR examination performed, and a lot of these patients also underwent study with late gadolinium enhancement, and more of these will be used in our centers. Now, the fourth guideline was on the diagnosis and management of acute pulmonary embolism, and again here, imaging plays a central role. As we know, these patients can be very sick, and these patients may have to have very important decisions, for instance, in terms of reperfusion therapy. And here, the use of two imaging modalities are particularly important. One is CT. So if there is a patient with a suspected acute pulmonary embolism who presents with shock or hypotension, and if CT is available, this is a class 1C indication, and this can actually be the indication for immediate reperfusion therapy. If it's not available, then the use of echo is considered as a class 1C, particularly to look at the evidence or the presence of right ventricular overload or right ventricular dysfunction, which we know it's a sign of acute pulmonary embolism. So again here, imaging playing a central role in the management of patients, in this case with acute pulmonary embolism. So let's talk now about imaging atherosclerosis. We've seen already this picture. I think it's quite interesting because this was based on the fact that in murine models, acute MI exacerbates the atherosclerotic inflammation and progression. So the question was if it was the same in humans. So these authors from the UK, they actually did this study, and they look at patients with stable angina, non-STEMI, and STEMI, and they showed by using PET that in the MI patients, the PET activity was correlated with the size of the infarct, and the size of the infarct defined by the troponin level, demonstrating again, looking at the regions of interest around the aorta, that there was this correlation between the size of the infarct and the development of this, or the presence of this inflammatory atherosclerotic markers. And this was also shown by Keith that in this large registry, the GRACE registry, the size of the initial infarct was an independent predictor of recurrent early MI at 30 days, and we can see here the different terciles based on the troponin levels, and therefore the conclusion that MI exacerbates systemic atherosclerotic inflammation, destabilizes remote atherosclerotic plaques, and therefore causes an increase in early recurrent atherosclerotic events, and again here imaging demonstrating some of these features. Another interesting set of presentations was actually on something that the ones of us who do imaging for a long time, we've seen for a long time, and sometimes we're not paying too much attention, but in the recent years there's been a lot of interesting looking at this specific marker, which is the epicardial adipose tissue. And here what these authors went to look at was the relationship with plaque characteristics and the vulnerability of vulnerable plaque and the thickness of the epicardial adipose tissue. In this case, over 400 patients were studied with 64-slice CT, and they look at three different aspects: low-density plaque, spotty calcification of positive remodeling, as markers of a vulnerable coronary plaque. And then they went to look, and they showed that in all the cases there was an increased thickness in this epicardial adipose tissue, and when looking at the multiple logistic analysis after adjustment for age, hypertension, and dyslipidemia, the high-risk plaques were identified with an increased in this epicardial adipose tissue, and the threshold here was put at 5.6 millimeters, so demonstrating some correlation between this thickness of the epicardial adipose tissue and the presence of vulnerable plaques. The other interesting presentation was this one, which actually went to look at a set of over 3,000 subjects which were followed up for 5 years and went to look at the correlation between the thickness of the epicardial adipose tissue and the progression of coronary artery calcification by using CT, and again demonstrating that there was a correlation between this thickness of epicardial adipose tissue and progression of coronary artery calcification, which again it's interesting observation and something relatively new on the use of imaging. Finally, I will talk a little bit about now the assessment of left ventricle, which we know is one of the main areas from a clinical standpoint where we want to have reliable and accurate measurements of function. Until now, until recently, we're still using a surrogate of left ventricular function, which is ejection fraction, but we do know the limitations of ejection fraction, which basically is just based on volumes, end diastolic volume minus end systolic volume over end diastolic volume, so it seems a very crude way of assessing left ventricular function. So many other imaging modalities, and particularly the ones who can actually assess myocardial function, have been developed some new parameters trying to identify new surrogates of function. And this can be particularly useful in some subsets of patients. And this is one of the cases in this study, which is patients, this is a set of patients with breast cancer who underwent chemotherapy, actually radiotherapy, and were undergoing chemotherapy. And we know how important it is to have a good assessment of left ventricular function in these patients because many of the drugs that are used as chemotherapy, they are cardiotoxic, and it's very important that we determine the impact of these drugs in terms of left ventricular function. So what was studied here was trying to use a different imaging modality, which is the 2D spectral tracking. I will not get into details, but it's basically a method based on ultrasound, which provides you an objective assessment of myocardial function. And here, what they went to look at was at 40 women with left-sided breast cancer. They were treated first by lumpectomy, and they underwent adjuvant radiotherapy. And then they were studied by using this 2D spectral tracking at baseline, during radiotherapy, and then at 6 weeks after radiotherapy. And then different parameters were used, including ejection fraction, but the two parameters that were more accurate in terms of defining, correlating with radiation dosage, and detecting early changes in left ventricular function. And again, patients with preserved ejection fraction, but some of these patients already demonstrating some impairment in longitudinal function by using radial function by using two of these parameters, which is the so-called global longitudinal strain, which provides you global information in terms of longitudinal function, and also global radial strain, which provides information in terms of radial function. And these findings may actually have potentially implications in the treatment of these patients, particularly the ones who will receive additional cardiotoxic chemotherapy. So again, one potential use, and there have been actually other trials and other studies in other clinical conditions looking at these parameters as potential new surrogates, let's say new ejection fractions that will replace the old ejection fraction as the only surrogate for left ventricular function. Still some work to be done, but it opens the door here to look at new parameters that can detect early changes in left ventricular dysfunction. Now, the other interesting presentation, and again trying to find new parameters, new surrogates of left ventricular function, is actually a new parameter which is using now 3D spectral tracking echo, and looking at this specific parameter which is area strain. And in this case was also in a set of patients, which is also a concern. And these are asymptomatic patients with severe primary mitral regurgitation and still with preserved ejection fraction. And the question is, can we identify the patients who may actually be suitable for and should be candidates for early treatment, and these are usually patients who will undergo surgical treatment. And this is a very difficult group of patients because they are asymptomatic patients and they have normal left ventricular ejection fraction. So what they went to look at here, there were a small group of patients, 41 asymptomatic patients, so in these clinical conditions, and they were followed up for 18 months. And 8 of these patients, they develop one of the composite endpoints, either new onset of dyspnea or admission for heart failure, which, as we know, once looking at the guidelines, this is the recommendation then for surgery in these patients. But actually what was shown in this study was that the patients who developed these clinical conditions, they had a higher area of strength. So there was a difference in terms of the area of strength. And again here is the possibility that opens the way to select, to identify the niche of patients in these conditions that may benefit likely from early intervention. Again, preliminary work, but that certainly opens the way for looking and developing new parameters of left ventricular function that can help us to identify, in this case, patients who may benefit of earlier interventions. So I would say that and again, I'm just giving you a flavor of some of the studies that were presented in Barcelona. There are many others, but we can summarize by some of these take-home messages that on one hand, imaging now plays a major role in the diagnosis and decision-making in cardiology, and the fact that now it's included in the core of the guidelines is a very important sign of that. Second, that acute myocardial infarction exacerbates systemic atherosclerotic inflammation and disease progression, and this was shown by the study I've shown you with PET. The third take-home message, epicardial fat is a confirmed marker of advanced atherosclerosis. And finally, that left ventricular ejection fraction underestimates the extent of left ventricular dysfunction, whereas the development of these new parameters like 2D, 3D strain imaging can accurately detect left ventricular impairment at an earlier stage, and this can be particularly useful in some subset of patients, like patients with breast cancer that will undergo chemotherapy, or patients with primary mitral regurgitation still in an asymptomatic state. So, ladies and gentlemen, it's been a privilege to be here today, and just to remind you that next year we'll have another big Congress, this time in London, 29th of August, 2nd of September, and we're very much looking forward to welcome you again. So again, muchas gracias.
So thank you very much, Fausto. Now it's my pleasure to invite Dr. Patrick O'Gara to the podium. He will talk about the best of ACC 2014. Dr. O'Gara is the president of the American College of Cardiology, and we are really pleased to have him with us today. Pat?
Muchas gracias. Buenos dias, ladies and gentlemen. Thank you very much for the opportunity to present to you some of the highlights from the ACC meeting in 2014. And let me apologize beforehand, because it seems so long ago that the meeting took place. It's been more than 7 months, and you have already heard very succinctly and in typical erudite fashion from Professors Fox and Pinto regarding the most recent highlights from their spectacular meeting in Barcelona just last month. But let me do what I can to refresh your memory on some of the issues that were addressed at our Congress around April 1st of this year. The first topic that I'd like to discuss with you has already been reviewed in some detail by Professor Fox, but it would be difficult, I think, to discuss what some of the major outcomes were from our Congress without drawing attention to the results of the Simplicity 3 study. Now, it's fair to say that we're all convinced that renal artery denervation would have a tremendous impact on patients with refractory hypertension, defined as the persistence of hypertension despite 3-drug therapy that typically includes a diuretic. And you might recall these results, which extended over 3 years from the Simplicity 1 study, showing these spectacular reductions in systolic and diastolic blood pressure over 3 years following renal denervation in a group of patients with refractory hypertension. So Deepak Bhatt, who is a colleague of mine from Brigham and Women's Hospital, presented the results of Simplicity 3 at the ACC meeting in April. And this, you will recall, was really the first prospective, multi-center, randomized, blinded, and sham-controlled study to evaluate the safety and efficacy of renal artery denervation. And perhaps Dr. Pocock, in his comments, might discuss the importance of the sham control when assessing device and interventions of this nature. Dr. Bott and colleagues enrolled some 535 patients, and I would point out that these were from participating U.S. centers. This is the trial scheme, and there was a relatively long lead-in phase over which patients were verified to have refractory hypertension before they underwent a renal angiogram to exclude the presence of important atherosclerosis or fibromuscular dysplasia, which, as you know, are two causes of renal artery-related hypertension, and then underwent either a sham procedure or a renal denervation procedure and were followed over time thereafter. The primary endpoint of the study was office blood pressure at 6 months. And what Dr. Fox presented was a corollary finding of ambulatory blood pressure at 6 months. But the primary endpoint of the study was office blood pressure at 6 months, and this duplicates what Professor Fox has shown with respect to the ambulatory blood pressure assessment. Office blood pressure assessment demonstrated a reduction in systolic pressure for the sham control population as well as for the population who underwent renal denervation. And as you can see here, both groups achieved a significant reduction in systolic pressure, but there was no difference between group systolic pressures at 6 months. What did we learn? Well, we did learn that perhaps there are some limitations of this type of intervention, and a bit of criticism has been directed to this particular trial and others like it because we did not biologically confirm the extent or adequacy of denervation, either with biochemical testing or with imaging. And this particular question has driven continued studies in this particular field to determine whether or not there is a means by which you can verify the adequacy of a denervation procedure prior to concluding whether the intervention is useful or not useful. I think time will tell whether this sorts out. So, as I stated before, the results of this particular study underscore the importance of both blinding of the patients in this particular study design, but not blinding of the operators, and sham controls, and there will be further study. I think that this is a wake-up call to those of us in the cardiovascular community with respect to how it is that we should interpret the results of studies that may have some methodologic flaws with respect to their design. Now, Professor Fox has also already touched on the management or treatment of non-lipid targets to reduce the risk of coronary or vascular events over time. The stability study preceded the solid TIMI study that Dr. Fox has already nicely reviewed. Harvey White from New Zealand presented the results of the stability study at the ACC meetings, and this also was an investigation of daraplidib therapy in patients with ischemic heart disease. Remember that lipoprotein-associated phospholipase A2 is actually an enzyme that works on a substrate of oxidized LDL, the end products of which are responsible for destabilization of plaques and or the growth of plaques by virtue of sustained inflammation or an expansion of the elements within the necrotic core. It makes biologic sense that interference with this particular enzyme might thereafter reduce plaques that could become vulnerable and then secondarily reduce coronary events. This too was a very nicely and well-designed study of patients with stable ischemic heart disease, Nearly 16,000 patients randomized to a single daily dose of the active drug, daraplidib, which as you know is a monoclonal antibody, versus placebo, and a median follow-up of nearly 4 years or 1,600 clinical events. And as has already been shown, these patients were very well treated with respect to the standard of care, raising some issues as to whether or not a study of this sort with a relatively low event rate because of the current standard of care would be able to show a difference between experimental groups. As you can see here, the use of aspirin, statins, beta blockers, and inhibitors of the renin-angiotensin-aldosterone system was quite robust. And as is also the case for the TIMI 52 study, absolutely no difference with respect to time to first occurrence of cardiovascular death, MI, or stroke, a triple composite primary endpoint, as you can see here. Fortunately, there were no serious side effects from the use of this medication other than a change in bowel habits, which, if medications of this sort are ever proven to be effective, might limit their usability. There were some signals of possible benefit in subgroup analyses, but of course we've been chastened by looking at subgroup analyses in the past, and we have learned lessons that perhaps a subgroup analysis in a trial that fails to meet its primary endpoint might be difficult to expand or extend over the care of patients. But signals in patients who are Caucasian and signal of potential benefit in smokers, time will tell whether this bears out with additional study. So daraplidib showed no significant reduction in the incidence of the triple endpoint, a possible signal of efficacy, but let's be very cautious about that. And fortunately, it did prove to be safe. So this begs the question as to where we're going with the treatment of inflammation per se as a means by which to reduce vascular events long term. This is just one study currently in progress funded by the National Institutes of Health in the United States. It's called the CERT study, and it actually looks at the use of the drug methotrexate as a primary anti-inflammatory agent in patients with ischemic heart disease to determine whether it, in combination with optimal medical therapy, will reduce vascular events over time. Primary investigator here is another colleague of mine, Dr. Paul Ritker. Why would a study be designed with methotrexate? This actually derives directly from observations made in patients with rheumatoid arthritis treated with methotrexate, and the observation that the use of methotrexate in that patient population, with obviously a high titer of inflammation, has been associated with a reduction in coronary heart disease events over time. Now, whether that's a causal association or not remains to be determined, but this is an attempt to try to get to the question of inflammation independent of lipids, and time will tell how this sorts out. So if inflammation is not yet a target of therapy, how is it that we should go about risk stratification with respect to trying to make decisions as to who among our patients who have yet to have a coronary event, that is, those patients who require primary prevention, who is a candidate for moderate to high intensity lipid therapy according to the recently now released ACC, AHA, NHLBI guidelines for treatment of blood cholesterol disorders. This particular guideline has created a bit of havoc in the United States, as you might know, certainly within the primary care community as well as in the cardiovascular community. But you will recall that that particular guideline identified 4 classes of patients who should be able to predictably benefit from the use of statin therapy to reduce atherosclerotic vascular disease events. Patients who've already had an event, patients with diabetes in a certain age group with a certain LDL cholesterol, patients with primary cholesterol disorders characterized by an LDL in excess of 190, and then this huge population of generally middle-aged patients who have a risk score somewhere in the range of about 7.5%, a risk for heart disease or stroke over a 10-year time horizon. And when things become fuzzy, there actually is a recommendation to use other potential factors that may influence your discussion with your patient with respect to the potential efficacy of statin therapy to reduce events, namely an LDL cholesterol in excess of 160, an elevated lifetime risk of atherosclerotic vascular disease events, as predicted by Dr. Don Lloyd-Jones and others in their risk assessment papers generally published in Lancet and Circulation, a family history which in many instances seems to trump anything that we can measure in the blood, particularly a family history that includes that of a sibling with an atherosclerotic disease event at young age. And then, of course, this is what the point is that I'm driving to, the presence of a CRP in excess of 2 milligrams per deciliter, 2 milligrams per liter, according to a high sensitivity analysis. This also, I believe, remains controversial across the world, as there are differences of opinion with respect to the role of CRP independent of the influence of other factors on predicting the likelihood of an atherosclerotic disease event. But nevertheless, it is there largely on the basis of the Jupiter trial with which we have become familiar over the past several years. I think these studies looking at inflammation as a target for therapy might help us answer these particular questions in a more definitive way. The lipid therapy I can summarize briefly by showing the same slide or a similar slide that Professor Fox showed about monoclonal antibodies to PCSK9, which is an enzyme system designed to destroy LDL receptors. So an antibody that inhibits this particular enzyme system and makes more receptors available should therefore reduce LDL cholesterol levels in the serum, and this has been shown in multiple trials presented both at the ACC and in the ESC in multiple types of patients. Heterozygous familial hypercholesterolemia, those on statin therapy, those who cannot tolerate statin therapy, and everything in between. I think we have demonstrated on multiple occasions these agents work, these agents appear to be safe, and what we yet to know is whether or not these agents will reduce clinical events to justify their use, particularly among patients who cannot be treated to adequate targets with statin medications. There have been some trials at ACC and elsewhere that have focused our attention on rapid diagnosis of myocardial infarction and triage of patients with acute coronary syndromes. I always put up a slide like this with the following caveats. Who wants another more high sensitivity troponin assay? Which of you out there, or who of you out there would like to be called to see yet another patient with a troponin elevation in the context of some other kind of clinical illness? Thank goodness that we've spent some attention recently on the definition of myocardial infarction and trying to separate type 1 myocardial infarction from all other types of myocardial infarction. But this does provide us with, I think, a lot of headaches. You remember the troponins, of course, are regulatory molecules that sit within the actin-myosin filament and do regulate calcium and then the interactivity of these particular muscle proteins with eventual contraction. And similar to what Professor Fox has shown, a late-breaking trial at the ACC in 2014 used the following observations about undetectable high-sensitivity cardiac troponin T levels in the emergency department to inform physicians and patients about risk of myocardial infarction. The hypothesis was that all patients with chest pain who have a first undetectable high sensitivity troponin T using this assay, independent of the duration of their symptoms and an ECG without signs of ischemia can be discharged directly from the emergency department because their risk of myocardial infarction within 30 days is either non-existent or minimal. This looked at 330,000 visits over 2 years and analyzed about 14,636 patients, and then stratified them according to the concentration in the blood of a high-sensitivity troponin T assay. And we'll look specifically at those who were defined as having either none or undetectable levels, namely those with less than 5 nanogram per liter or picograms per milliliter. And as you can see here, with the high sensitivity cardiac troponin T level that was either minimally or undetectable, the negative predictive value for a myocardial infarction over 30 days was nearly 100%. So I think in a very similar fashion to what you've already heard, a first undetectable troponin T level using this assay for high sensitivity without signs of ischemia on the ECG ruled out a myocardial infarction with 100% accuracy, and in addition, regardless to the duration of symptoms. The timing of the measurement of the troponin T level, prior disease, age, gender, or other risk factors for myocardial infarction. I think this is a welcome addition to our armamentarium with respect to the evaluation of patients in an emergency room setting to become more efficient and to have increasing levels of confidence that patients can be discharged at low risk. There is an additional study looking at CT angiography versus stress ECG testing in patients admitted to emergency departments with chest pain and suspected acute coronary syndrome. This looked at a randomized total of 562 patients, and they were allocated between standard of care with exercise ECG testing to assess for the presence of ischemia, and then a coronary CT angiographic arm using a dual source CT scanner in order to reduce radiation exposure. And as you can see here, there are relatively few numbers of events around a patient population presenting with chest pain and suspected ACS. The vast majority of these patients did not have ACS. I think that's an accurate reflection on what happens in our emergency room. But look here at the receiver operating characteristics in the area under the curve. For coronary CT angiography among patients with 50% or less stenoses or 70% or less stenoses, the area under the curve significantly higher with CT compared to stress electrocardiography, negative predictive value, which is 100% for both types of modalities. But in addition, the cost of this kind of an evaluation was lower in patients who were directed down a pathway that included coronary CT angiography compared to those who stayed for a longer period of time and had exercise ECG, in addition to which there was about a 7-hour differential in total length of stay. So this, like other studies of its type, begins to, I think, inform us about the potential utility of imaging, not a physiologic assessment, but imaging in addition to clinical assessment for decision-making around the likelihood of ACS and, of course, the likelihood of myocardial infarction. Valvular heart disease was featured at our meeting in 2014. Think back, if you can, this venue afforded an opportunity for the core valve investigators to present their data on the use of the Medtronic core valve as one means by which to perform transcatheter aortic valve replacement. And in their particular trial, they showed that among high-risk patients referred for valvular intervention, in this study, patients allocated to core valve transcatheter aortic valve replacement had better survival compared to patients who were randomized to surgery. This raises the stakes with respect to operator or physician choice of the appropriate type of aortic valve intervention among patients who are considered to be at high risk, as defined in that trial by an STS risk score that exceeded 8%, or a Euro score typically that 20%. But as we've seen from Professor Fox's presentation, we now have information on thousands of patients, including those in randomized trials, showing the utility of this particular type of technology, and there will certainly be more to come. The ACC meeting also provided us with a venue to introduce our new valve guidelines. Perhaps you've had a chance to look at these and compare them to the typically wonderful ESC guidelines that were, I think, most recently revised and published in 2012. Dr. Vahanian is a close colleague of ours, and we communicate a great deal about what's new in valvular heart disease and how to approach decision-making as a global community of physicians. What's new in our guideline that might help you with respect to your understanding of this very interesting aspect of cardiology? Well, we attempted to utilize an assessment of the natural history of valvular heart disease in a way that's very similar to what we have adopted in the United States when looking at patients with systolic heart failure, stages A, B, C, and D. And I'll show you that on this next slide. The stages of valvular heart disease begin among patients who are at risk for the disease, who have then a long latent period of progression, who then develop severe yet asymptomatic disease, typically defined by echocardiography, and then who may eventually undergo a conversion to a symptomatic status. In addition, there's emphasis placed on the guideline in making sure that we assess carefully patients with asymptomatic severe disease, making sure that we can account as to whether or not the disease process has already started to impact unfavorably on left or right ventricular function as assessed by a variety of techniques. We happen to think that this is a useful way to understand the natural history of the disease. I think time will tell whether our readers agree. We did spend quite a bit of time on risk assessment, and we think in the modern era, risk assessment should include much more than simply calculation of a Euro score, or in our country, an STS risk score. We need to account for frailty because we're operating or intervening on patients who are much older and have a much more robust portfolio of significant comorbidities. We have to account for major organ system dysfunction that's not included in an STS risk score. And then, of course, from a surgical point of view, we have to look at procedure-specific impediments that can make the task of the surgeon much more difficult than we as cardiologists could understand. So a patient who is considered to be low risk should meet all of the following criteria: a low STS risk score, no frailty, no major organ system compromise, and nothing of a predictable or identifiable nature that would impair the surgeon's ability to get the best result. And look over here for high and prohibitive risk. These are patients who have higher scores, but also who may have one or two elements of frailty and organ system not accounted for in the STS risk score, and then something in the chest that could make surgery difficult, such as previous radiation therapy. We also spent a lot of time trying to define the use of the heart valve team and what it is that constitutes a heart valve center of excellence. These are extremely important issues, I think, in the modern era when we begin to function in teams in order to provide best care to our patients. And with respect to defining a heart valve center of excellence, it has never been more important. If we're going to talk about intervention on asymptomatic patients at earlier stages of their disease process, we have to be very confident in surgical outcomes and being able to tackle a problem such as this, what defines a surgical center of excellence, in addition to being able to understand what their outcomes might be and the fact that that center participates in a national or global registry and benchmarks itself against others. So I very much appreciate this opportunity. I apologize for any overlap, but you can see we share the same problems. We're lucky enough, I think, to be able to participate in the scientific discussions of many of these things, both simultaneously as well as in parallel with each other. It's wonderful to be here with my colleagues from the Spanish Society of Cardiology and my colleagues from the European Society of Cardiology. We look forward to seeing you in San Diego, where lots of people speak Spanish. Thank you very much.
Yeah, and now it's really a great pleasure to me to introduce the lecture of Stuart Pocock. All of us learn so much from the Stuart Pocock work during the last years, and Stuart Pocock work continues to make terrific contributions to the science, but particularly terrific contributions for the quality of care of our patients. And particularly to me, it's a great pleasure that Stuart Pocock being here in Santiago. So, because the last year I have the opportunity to know very well Stuart, and it's a great opportunity for all of us having Stuart Pocock here in Santiago discussing about science and about cardiology science, where Stuart made terrific contributions. Thank you, Stuart, for coming.
Many thanks, Juanate, for that very kind introduction. I'm going to try and do something different. You can get a hint that it's different by the fact that I'm clearly not a cardiologist. There's no jacket and tie. That kind of indicates that. I am, in fact, a statistician. And that expression is usually followed by either a nervous silence or comments like, "I'm sorry, how awful." But given that handicap, I'd nevertheless like to do a review, which I hope is entertaining and informative, and what I think the state of the art is on clinical trials research in cardiology. I'll start with a celebration, move to a calamity, and then go through various controversies. Oops, sorry, I went too quickly. No, hold on, it's just slightly sensitive. What I see as a celebration is what I think was the most positive, exciting result out of this year's ESC, which Keith Fox has already mentioned. I sit on many data monitoring committees, and it's really rather exciting when you're able to stop a trial early because you're seeing remarkable superiority. So the paradigm trial, as Keith already pointed out, was LCZ 696. Sometime soon they'll think of a better name. Versus enalapril in chronic heart failure. The primary endpoint was cardiovascular death or heart failure hospitalization, and the key secondary endpoint was cardiovascular death. And thank goodness they made it a very large trial, because it's 8,000 patients, and you will need that very large trial to prove something or to show evidence that something is better than an active comparator. It was an event-driven trial, so the trial was meant to continue until 2,400 patients had had the primary event. But we had interim analyses, 1/3, a half, and 2/3 of the time through the trial. And we recognized the importance of not stopping early unless you had proof beyond reasonable doubt of superiority. And now these sort of small p-values, I thought, we'll never get to that sort of evidence. But I was wrong, because we did. In March of this year, at the third interim analysis, the Data Monitoring Committee met and were looking at the following results. There were substantially fewer primary events occurring in patients, and the p-value was kind of off the scale, highly significant. And cardiovascular deaths was also showing a markedly reduced number of cardiovascular deaths. Of course, in any interim analysis, you're faced with adjudicative events, and therefore you're waiting for certain patients to know whether the death was really cardiovascular or not. So we also added in those deaths where we needed to rely on the investigator verdict, and that pushed the p-value to be even smaller still. And there was an interesting trend on all-cause death too. So we felt, even though the trial was nearing its end, we felt it was appropriate to stop for superiority in this particular instance. Now, when you stop for superiority, you have a slight anxiety, because there'll be more data to come in between when we as a committee made our verdict and what the final database exists. So I was expecting this might regress to the truth, be less impressive, but actually it got slightly more impressive. And if only all investigators dream of these p-values, but very rarely get them. And this was the exciting result of the Paradigm trial. Here shows the primary endpoint. You still see, even though it's overwhelmingly significant, you could argue that the effect is modest. But it's large trials with modest benefits that really are where the important advances will take place in cardiology. So that's something to celebrate. Now, renal denervation has already been mentioned twice, so I'm going to be very brief and just mention my take on it. So the Simplicity 3 trial failed to show any benefit, and it was renal denervation versus a sham procedure, a 2-to-1 ratio. That is interesting because it contradicted the previous uncontrolled and unblinded trials. So the uncontrolled trial had showed a massive reduction in systolic blood pressure on renal denervation. A randomized control, but unblinded, so everyone knew who was getting what, also showed a massive reduction compared with not doing renal denervation in resistant hypertension. So what Simplicity 3 showed very little difference, and this was a great surprise, and it showed the importance of having a valid, unbiased comparison with a sham procedure. So what we're showing is, if you have resistant hypertension, but we pretend to do renal denervation, that's actually good enough. You don't actually have to do it. And that is a very important signal for us to realize about the power of the placebo. Patients with resistant hypertension can have their blood pressure reduced by suggestion rather than actually doing renal denervation. It could be that this was also some regression to the mean by patients who were on a particularly high point of blood pressure at the time they were entered into the study. But the single explanation is the device is ineffective. There are counter-arguments. Were the patients selected not quite appropriate? Were they not really with resistant hypertension? Was there an imbalance in drug use during the course of the trial? Were those on the sham getting more drugs? We think not. Or was the operators inadequately trained to deliver the procedure appropriately? And now the sponsors of more than one type of renal denervation device are rethinking their strategies for the future. So watch this space. The game is not over, and we may find there are other trials to come along, probably with sham procedures. See, so don't believe single-arm trials, don't believe unblinded trials. This gets you nearer to the truth. No more research is required. This has something general to say about trials of medical devices in Europe. The CE mark, whereby a device is approved to be marketed in the EU, typically does not require randomized trials. It just requires uncontrolled study to show that you can actually deliver the device. And therefore, stents, TAVIs, renal denervation are readily approved much faster than the United States, where the FDA required properly conducted randomized trials. So we have the contrast between speed of approval in Europe, which is okay if all goes well, but then if you don't do any research, of course things will go quickly, and thoroughness in the US, which is necessary to establish efficacy and safety. So one of my more important general messages is this need for a radical improvement in the way that we approve medical devices in Europe. Next, I want to talk about the pharmaceutical industry and the fact that the contrast between the trials we'd like to be done for public health interest and the trials that get done for industry's interests in showing that their drug is a good thing. I want to talk about the role of bivalirudin in patients who have undergone primary PCI. There are two main trials which were predominantly sponsored by the medicines company. The Horizons trial was investigator-initiated, but had a large amount of funding from the medicines company. And there, the comparison is bivalirudin alone versus heparin plus GP2B3A inhibitor. And it showed that for major bleeding, bivalirudin had less. And if you look at net adverse clinical events, that's including cardiac events in addition to bleeding events, they also look to be better. The Euramax trial, done in Europe of course, was somewhat similar, and again the same contrast of bivalirudin, but not compared with heparin alone, but always compared with heparin plus a GPI, usually up front. And therefore, again, they showed death plus major bleed was less on bivalirudin, but there was hinted that all is not well by the fact that reinfarctions were somewhat higher on bivalirudin, but not formally significant. So if you take these trials, bivalirudin alone looks superior to heparin plus GPI. Then came a really interesting trial, the HEAT PPCI trial presented at the ACC this March. It's antithrombotic therapy, heparin versus bivalirudin, but with selective use of GPI equally between the two treatment arms. Then you see a totally different picture. The primary endpoint, MACE, which comprised death, stroke, and reinfarction, showed a significant excess in bivalirudin, P of 0.01. This was even more dramatic if you look at stent thromboses, where there were those small numbers, as you would expect, nevertheless substantially more on bivalirudin. And major bleeds, one should remove the GPI up front from heparin, there was really no difference in major bleeding. So here you would say this trial seems to suggest that actually heparin is more efficacious and equally safe. And that shows the marked difference in that trial on the MACE events. So here we have a contrast that another trial in ACS was also looking at heparin plus GPI. These trials were all sponsored by by industry, and the GPI was added to standard cheap comparative heparin. And as a result, they made bivalirudin look very good. But the HEAT-PPCI trial suggests that way of thinking may not be appropriate. It has its problems. It was a single-center trial in one centre in the UK, Liverpool, and done predominantly with public funds, with a head-to-head comparison. And it randomized all eligible patients, which is why it managed to be such a large trial in one centre. So I think this means that we need more public-funded trials, or industry can sponsor them if they like, looking at an equal head-to-head comparison of bivalirudin versus heparin to see where bivalirudin really stands. This leads me to make a more general perspective about industry-sponsored trials. Demetz and Califf, excellent researchers in cardiology trials in the US, said rather seriously, where have all the academics gone? We need a better balance between commercial interests and public health. That is critically needed for the future. The problem is we have many trials which have no commercial value to their sponsors. Maybe the drug is past its patent, and it's very hard to get such key trials actually funded by public funds, and therefore we have many questions that are clearly important that go unanswered. I'll take one established old set of drugs, the beta blockers, and I see three trials that are really important to see. Beta blockers are post their patent, and therefore it's unlikely industry will be intended in such trials. For instance, what's the role of intravenous metoprolol before reperfusion in STEMI patients? We have a pilot study published in Circulation looking at reduced infarct size and improvements in left ventricular ejection fraction. And now what we need is a larger, longer-term, double-blind placebo-controlled trial to assess the effects of metoprolol in this context on clinical events. That's number one. Beta blockers are also very controversial in what their role is in non-cardiac surgery, because two past key trials favoring beta blocker have declared invalid due to potential fraud in the way their data were collected. And the ESC guidance recently has been rewritten to say the evidence is inconclusive. And the largest trial of metoprolol actually showed an excess mortality, perhaps because it was given at too high a dose in the context of non-cardiac surgery. So what we now need is a new large placebo-controlled trial to study the role of beta blockers in high-risk patients undergoing non-cardiac surgery. How are we going to get these trials funded? Another one is about withdrawal of treatments. Take patients with stable coronary disease. They take several drugs: aspirin, beta blocker, statin, ACE inhibitor, maybe antihypertensives, antidiabetics, and maybe others. Industry-sponsored trials tend to be placebo-controlled trials, always geared to adding an extra drug on top of these that already exist. So we want to get away from that paradigm sometimes to ask, when can a drug actually be withdrawn in the context of all the others we're already giving? Either because it becomes ineffective or because it's actually harmful. And so which patients, which drugs, and which outcomes are ripe for this type of investigation? One possibility would be patients undergoing PCI for stable coronary heart disease who are already on a beta blocker. Can you withdraw the beta blocker post-procedure? And we need a trial looking at clinical events to see if it's safe and wise to withdraw beta blockers, because otherwise we're in the paradigm of cardiology. Every drug is sort of thought of as forever, and we need to get away from that way of thinking. Another interesting question on drug withdrawal is, after a drug-eluting stent, how long do you need to give dual antiplatelet therapy? The standard being aspirin plus clopidogrel. This is a trial called Optimize, which randomized patients to either getting 3 months or 12 months dual antiplatelet therapy. The primary endpoint was net adverse clinical and cerebral events, called NACE, that is death, infarct, stroke, or major bleed out to 1 year. It was a non-inferiority trial intended to show that 3 months was as good as 12 months. And it seemed to pass that level of criterion for the composite primary endpoint we're looking at here. There was no difference, and the confidence interval ended up under the pre-declared non-inferiority margin. So in that sense, it seemed fine, but actually we know that most of these events are probably unlikely to be influenced by the duration of DAPT. We're really concerned about two rare events. One, a stent thrombosis may be increased if you stopped DAPT. And there's a hint that that's the case here, but it's only 4 events versus 1. Major bleeding may be increased by continuing DAPT. Again, small numbers, 3 versus 6. So the trade-off between the small risk of a stent thrombosis and the small benefit of less bleeding, this trial was actually a bit too small to answer that more subtle and appropriate question. The major trial of this area is called, oddly enough, the DAPT trial. I think it's got something like 20,000 patients, and I think it's going to be presented at AHA next month. It's an excellent trial of the wrong question, because it's studying 12 months DAPT versus 30 months DAPT. And I think we've now moved on to think, can we give less than 12 months? But nevertheless, I look with excitement to see what their results show. How does this all work out? And it's a more general question of how do trials influence guidelines, and how do guidelines influence clinical practice, which is what really matters. How well is this working? For duration of dual antiplatelet therapy, one size doesn't fit all, in the sense that you may vary the duration according patients' bleeding and cardiovascular risk, whether it's ACS versus stable disease, whether it's a drug-eluting stent or a bare metal stent, and perhaps whether they're diabetic. But in general, trial evidence suggests that 12 months is sufficient. Maybe less would be in many cases. And the current European and US guidelines support this kind of somewhat general statement. What's actually going on? Well, I've been working with a real-world registry, not a trial, of patients discharged after an acute coronary syndrome hospitalization. It's called EPICOR. It covers 500 hospitals in 20 countries, both in Europe and in Latin America. And studying the 9,000 patients who were discharged on DAPT, at 21 months, 64% of them are still on DAPT, which is much higher than the trials and guidelines would justify. And this excess treatment beyond guidelines needs more attention, I think. Now let me turn to anti-diabetic drugs. And the FDA guidance for industry a few years ago precipitated a substantial number of large cardiovascular safety trials to see if any drug did not rule out an excess risk in various new anti-diabetic drugs. So here, these trials are focusing on patients with diabetes who are at high risk of a cardiovascular event. And the primary endpoint in these trials is usually cardiovascular death, myocardial infarction, and stroke, a composite. To get approval of your new drug, you need trial evidence to rule out an unacceptable 80% excess cardiovascular risk. But to stay approved in post-marketing safety trial, you need a longer, larger trial to establish cardiovascular safety more clearly. In the FDA's rules of the game, that means you have to rule out a 30% excess risk. Evidence of a cardiovascular benefit would be a bonus, but to date, no anti-diabetic drug has ever been successful in that direction. Now, I want to introduce to you a couple of the trials that have come to fruition out of that new guidance of the FDA. The first is the SAVOR-TIMI 53 trial of saxagliptin versus placebo. Very large trial, 16,000 patients. They made it so large because I think they were hoping for superiority. Massive adventure, median 2.1 years follow-up. You can see that the primary endpoint, CV death, MI, and stroke, was remarkably similar between saxagliptin and placebo. Hazard ratio of 1, so pretty well you can rule out anything happening there. Heart failure hospitalization, though, there was a hint of bad news because there was an excess, numerically, of heart failure hospitalizations in saxagliptin versus placebo. This has a hazard ratio of 1.27, which is formally statistically significant. So the primary endpoint, non-inferiority, was established, but with no benefit. Heart failure, is this a real problem? Or is it just out of multiple testing because we were looking at a lot of other secondary endpoints? So is it possible it's just a false positive? A false bad luck, if you like? And the answer is we don't know. The EXAMINE trial of alogliptin had a similar design, incidence of heart failure hospitalizations. It also came to non-inferiority for the typical primary endpoint. On heart failure hospitalizations in the EXAMINE trial, alogliptin had a numerical slight excess, but the hazard ratio was much nearer 1, and it was nowhere near statistical significance. Some have used this to argue that saxagliptin is bad, alogliptin is okay. I disagree with that simple conclusion. Because if you compare this hazard ratio with this hazard ratio, they are not statistically significant from one another. So I would say these are all in a secondary hypothesis, and at the moment the data are inconclusive. And the other trial, the other drug in this class, sitagliptin, we will await with interest the TCOS trial, which I think whose results will be presented sometime early next year. Now, let me turn to a trial analogous to the culprit trial that Keith Fox mentioned. It's a trial of looking at preventive angioplasty and myocardial infarction. In primary PCI, should you be treating the culprit lesion only, or should be treating other narrowed arteries as well? And this trial was published in the New England Journal last year. One thing to note, it was stopped early and also recruited very slowly. It was in the UK only, and it had a mean 23 months follow-up at the time it was stopped. The primary endpoint looked very impressive. That was the combination of refractory angina, non-fatal myocardial infarction, and cardiac death. You saw there were markedly fewer events on those receiving the preventive angioplasty on top of the culprit lesion. And it was very highly significant and seemed to be consistent in the different components, even in cardiac death. The numbers are very small. And there's an impressive looking Kaplan-Meier plot showing the marked difference between the preventive angioplasty group and the control group. But this trial, along with the culprit trial, provoke concern about how much can we trust them. Issues to consider is a huge treatment difference, especially in a trial which is small with rather few events. Is it all too good to be true? Is there an exaggeration of the truth? And is that likely to be the case, exaggerated, in a trial that stops early? because there's always a tendency to exaggerate efficacy in small trials that stop early. The trial was not blinded, has a potential for bias as a result. And do we generally think of it as hypothesis generating, more research is required, rather than a trial that is ready to change practice for the rest of you? So there's another large trial, the COMPLETE trial, which is in progress, which is thought to be more realistic by many in that it's looking the preventive angioplasty, the extra lesions intervened on, will be done in staged procedures during the same hospitalization, but not at exactly the same time as you're doing the culprit lesion. And so that's an interesting field still with more to come. This trial raises a broader issue of I think we need more pragmatic trials of alternative treatment strategies, because we need to tackle more key issues in patient management. Strategies are often fundamentally different. Should we do surgery or should we do another intervention, e.g. CABG versus PCI or aortic valve surgery versus the modern TAVIs? Or should we do more intensive management, starting with an angiogram versus more conservative management in patients with acute coronary syndrome? These are many important questions that are strategic. Now, the trouble is, compared to drug versus drug or drug versus placebo trials, they're much more difficult to conduct, more difficult to recruit sufficient patients. But the answers can often make a bigger impact on practice. So the best questions, the most difficult questions, are really important but difficult to do. So where do I stand on trials in general? What does society need from our programs of cardiovascular clinical trials? Number one, you need trials of importance to public health. And I think we need to do a better job balancing commercial interests alongside what we really need of benefits to patients. Asking the right question, which treatments, which patients, which outcomes really matter. Delivering unbiased answers, the sort of things I have a job in, randomization, blinding, and quality. And we need more efficient trial conduct. There's far too much excess bureaucracy, far too much auditing going on in clinical trials, and we need them more efficiently and more cheaply done. And the role of DMCs are obviously important in ethical conduct. We need trials to be conclusive and representative, so we need large sample sizes, international collaborations, and pragmatic real-world trials that relate to the real-world patients. We need trial publications that tell the whole story, that are balancing efficacy and safety in the appropriate way. On another time, I might have talked about personalized medicine, but that's not on my agenda today. Lastly, we need trial evidence that influences guidelines that impacts on best patient care. So we need a totality of evidence from a given trial program. Systematic reviews, meta-analyses are important when they're done well. When they're done badly, they're really awful. And we need all of this evidence to impact on routine practice. So my original title, there are some calamities going on in clinical trials, and there are many controversies. But in cardiology, I think we have a lot to celebrate. As I work across different disciplines, I think in general, cardiology does some of the best trials across the whole of medicine. But I leave a little hint that we must try harder to do better still. Thanks very much.
Thank you, Dr. Pocock. I will ask the speakers to come up because we have some questions in Twitter, and it's a pity we have gone a little bit over time because we will not be able to respond to all of them. Can you come here? Yeah. Okay, sí, yeah. So we had many questions, and we are very happy that we had questions from Mexico, from Argentina, and it was really, for me, that I was invited to do this for the first time by a club of young cardiologists. It's a good sign. So we have a question selected for each one of you. So for Keith, I mean, there is this question coming from Spain, coming from this room, which is for you the best advance of this year if you have to choose one?
For me, it has to be Paradigm HF, because, you know, these were patients that before the Congress we would have said are well treated. They're ambulant, they have modest symptoms, and yet there's a big impact on outcomes. So this will change our practice.
Good, thank you. For Fausto, we have a question from Argentina, so coming from far away. What should be the role of echo for pulmonary embolism in the emergency room in the new guidelines?
Well, it's a good question, because echo has always been playing a role in the emergency room in the patients who present with acute events that we have to rule out acute pulmonary embolism. And it's now a 1C indication, particularly if there is no easy access to CT, which should be the #1 imaging modality for these patients. But if it's not easily available, echo can play a major role, because it can show evidence of acute overload of the right side, showing there are many signs that you can see by echo that shows that you have a high suspicion of having an acute pulmonary embolism, and in that case help you to make the clinical decision to do, because the big question is to do or not to do emergent reperfusion therapy in these patients. So I think it plays a central role, particularly in the places where you don't have easy access to CT.
Thank you. So Pat, your question, do you think that renal denervation is a bad technique or just a bad performed procedure?
Well, I think the short answer to the question is, I don't know. My conclusion from looking through the Simplicity trials are the following. As Dr. Pocock has pointed out, we should never underestimate the value of placebo, particularly in hypertension trials. And number two, it is a fair criticism that in the studies reported to date, there has not been an adequate assessment of the degree to which renal denervation itself was technically successful. And because that question lingers, I think more research should be done, and it is appropriate to do so.
Good, thanks. And finally, for Dr. Stuart Pocock. So it seems clear that you think that all medical devices must require a sham control arm. So do we need more methodological rigor?
No, that would be too sweeping a generalization, of course. I think it's particularly true when you have a soft endpoint, such as blood pressure, which is very strongly influenced by suggestion. So I think more generally, they have their place, but if you have hard endpoints, myocardial infarction, mortality, etc., then I think sham procedures may be less appropriate. And you always have the ethics of shams to be concerned about too.
Perfect. Okay, thank you very much to all the presenters. And I want to thank also to Dr. Agustin Fernandez-Cisnal, who has been working here with the questions that we got. There were many, and he had selected these 4. And thank you very much for your presence here in this session. Thank you.